Good morning, Chairman and everybody. I am Dr. Rujima Kumthong, a neurointerventionist from Prince of Songkla University. I am honored to be here to give my presentation about imaging of complicated aneurysm. With increasing use of imaging for detection and follow-up of intracranial aneurysms, familiarity with the imaging features of complicated aneurysm is essential for modern radiologists and clinicians. There is no formal definition for complicated aneurysms. In this presentation, complicated aneurysms are defined as aneurysms that are increased risk of worse outcome in terms of natural history and need high-level therapeutic skills. There are many features recognized in association with complicated aneurysms. In this presentation, we are focusing on these major types. I want to look at the details of their treatment. I only want to talk about how to recognize them. Let's start with talking about aneurysms with complex configurations. The complex configurations is defined as irregular shapes, multiple lobes, or associated with vascular variations. These aneurysms increase risk of rupture or emboli and also need high-level therapeutic skills. The irregular shapes result from focal wall degeneration or intraluminal thrombosis. All sizes of small irregular or multi-lobe shapes secular intracranial aneurysms have been reported as they're associated with rupture. This slide shows imaging studies of 86-year-old woman presented with diffuse subnodal hemorrhage. You can see that there is an irregular aneurysm at the origins of the right precom right here. An irregular foul sac is protruding from the dome of this aneurysm. In this patient, endovascular coiling was done. Interprocedure rupture of the aneurysm occurred. Okay. Right here. Then the arterial coil loops were quickly packed into the residual sac to stop the bleeding. The bleeding was stopped, and the aneurysm was gone. And also the right precom right here, I'm sorry, was still patent. But however, there was increased amount of subnodal hemorrhage and also increased hydrocephalus. Now we come to bizarrely shaped fusiform aneurysms. These aneurysms have a risk of hemorrhage or ischemia related to thrombosis or emboli. A previous study proposed that spontaneous fusiform MCA aneurysm can cause by arterial dissection, like in this picture. Now we have another example of another patient who presented with intracranial hemorrhage related to a ruptured fusiform MCA aneurysm. This aneurysm was treated by surgical clipping. However, you can see there are some developed infarct after the treatment. Now let's move to aneurysm with vascular variations. From these images, you can see there are a ruptured aneurysm at an azygous ACA. The azygous ACA is a rare variation seen as a single A2 segment with absence of ACOM. The aneurysm at the azygous ACA is rare. Arterial damage or occlusion during the treatment can cause ischemia in both hemispheres. As the lower row images of this patient, you can see there are some embolic infarcts here in bilateral hemispheres after complete occlusion of these aneurysms. Now let's move to Thai-inr aneurysms. Thai-inr aneurysms are defined as aneurysm greater than 2.5 centimeters in diameter. These aneurysms are usually unvariable because they usually have wide necks, obscure the surrounding anatomies, and distort the parent vessels, and or incorporate branches at the base. Because of these findings cause Thai-inr aneurysm difficult to obliterate completely. So let's see Thai-inr aneurysms with partial thrombosis. Partially thrombosed Thai-inr aneurysm usually presents by mass effect, thrombi of different ages in an onion skin pattern surrounding a smaller partial lumen. These aneurysms also have a risk of recurrence after treatment. From these images, you can see this partially thrombosed Thai-inr aneurysm had 2 recurrences after complete obliterations in 2013 and 2014. And then complete obliterations again after recoiling. Now here are some slides looking at the wall enhancement of the Thai-inr aneurysm. The aneurysm wall is vascularized by a dense vascular network called vasovasorum. Right? The contrast enhancement at the wall of aneurysm gives a clear picture of high vascularity, some inflammations or some eventual bleeding from vasovasorum. Here are some slides looking at the intramural hemorrhage of the Thai-inr aneurysm. These images show that a new intramural hemorrhage. Close to the periphery of the Thai-inr aneurysm, this is probably suggestive of recurrent dissection between the layers of the aneurysm wall or repeated subaventral bleeding from vasovasorum. Because of this, partially thrombosed Thai-inr aneurysm may continue to grow even when the lumen of the aneurysm is completely occluded. Now we move to dissecting aneurysms. Dissection causes up to 10% of non-traumatic subnodal hemorrhage. The posterior circulation is more often involved than the anterior circulation. And acutely ruptured dissection are unstable and have a tendency to rebleed. The rebleeding rate is as high as 7% in the first 24 hours and 80% in the first week. In addition, rebleeding is associated with a mortality rate of up to 50%. There are some imaging findings that can determine a possibility of a dissecting aneurysm. On this angiogram, you can see a fusiform-shaped aneurysm with a proximal and distal narrowing. Right here. And CT scan shows diffuse subnodal hemorrhage of this rupture dissecting aneurysm at the right VA. This aneurysm was treated by a flow reversal technique using balloons. Okay, we have another example of a dissecting aneurysm at the right P1, P2 junction. You can see that the stack of these aneurysms had a jet flow and an intimal flap. It's a jet flow and intimal flap. Intimal flap is large. So the flow to the proximal portions of the stack came from the right P1 segment. So we put some coils to occlude the aneurysm from this side. However, this aneurysm wasn't gone because the flow to the distal stack, to the distal portion of the stack, came separately from the right PCOM. So we had to put more coil to occlude the entry from this side to get complete obliteration of these aneurysms. Now we move to infectious aneurysms. These aneurysms caused by infections, it usually affects the distal arteries and a proximal location close to the scalp base and cavernous sinus regions. Hemorrhage may occur often within 48 hours after exposure to the septic emboli. So let's see an example of mycotic aneurysms. Here are two mycotic aneurysms at the left P3 segment and a cilium branch of the left MCA. Of a 25-year-old man with infectious endocarditis. These aneurysms on CT, you can see that the aneurysm show enhancement and extending into the hematomas and some associated cortical ischemia. The mycotic aneurysm at the left P3 segment was treated by endovascular coiling with complete obliteration. However, refilling of this aneurysm occurs 6 months later after the complete coiling. So we have to add some coils to restore the complete obliterations of the aneurysm. Now let's move to traumatic aneurysms. Intracranial traumatic aneurysm can be subdivided into 3 types according to their location: scalp base, subcortical, and distal. The most often location is the cavernous segment of the ICA, and the most severe form is the torn ICA with rupture protruding into the cavernous sinus through a fracture at the sphenoid wall. Delayed bleeding of a traumatic aneurysm can occur from 5 days to 9 weeks after initial trauma. The mortality rate has been reported as high as 50%. Now we have an example of false traumatic aneurysm at the medial wall of the right ICA, which are protruding into the right sphenoid sinus through a fracture at the sphenoid wall. Small fractures here. And this patient presented with severe epistaxis 2 months after the initial trauma. So a balloon sacrifice of the right ICA was done to treat this patient. Now let's see another example of false aneurysm with active contrast extravasation at the basilar and PCA junction of a 17-year-old male who had had a motorcycle accident with multiple organ injuries involving diaphragm, abdomen, and pelvis. This patient died after uncontrollable deterioration in the angiogram room. So we will talk about previously treated aneurysms. The visualizations of a remnant or recurrent portions of the previously treated aneurysms can be obscured by surgical clips or coils, like in this patient with ACOM aneurysm after treatment by surgical clipping. On CT, you can see that a small remnant of the aneurysm is obscured by metallic artifacts from the cliff at this region. So the 3D angiogram can show the remnant better. However, in this patient, the cliff at the ACOM also caused difficulty to set a working projection for additional coiling for additional coiling. So let's move to blister-like aneurysms. Blister-like aneurysms are small sidewall bleb-like lesions that arise from non-branched arteries. Their size is usually less than 6 millimeters in diameter, 6 millimeters with a mean of 3 millimeters. A CTA is usually negative. Rapid change in size and morphologies can be seen on the follow-up angiogram. These aneurysms are fragile and have tendency to rupture or regrowth. Like this patient, the first image shows diffuse subnoid hemorrhage. And the angiogram and 3D angiogram show two small bleb-like aneurysms at the supracrinoid segment of the right ICA. The 3D angiogram shows that these aneurysms have broad neck appearance and broad base appearance and leg necks, as they originate directly from the non-branching sides of the right ICA. This particular aneurysm increased their size in 1.5 weeks and were finally treated by a floor diverter stent. Finally, we will look at multiple aneurysms. The prevalence of multiple aneurysm varies between 12 to 26% in clinical series. In patients with unruptured small aneurysms, multiplicity is associated with greater risk of rupture compared to single aneurysms. But in patients with subnoid hemorrhage who have multiple aneurysms and in whom it isn't clear which aneurysm has ruptured, one-stage coiling for all of the probably ruptured aneurysms may have to be done. Like in this patient, this is a 49-year-old male presented with diffuse subnoid hemorrhage. He was found to have 5 aneurysms on the 3D angiogram, including bilateral PCOM aneurysm, a left anterior choroidal aneurysm, and bilateral pericallosal aneurysms. It was unclear which aneurysm was ruptured because irregular shape found at bilateral PCOM aneurysm and the left anterior choroidal aneurysms. These 3 aneurysms were treated by coiling in the first session, followed by a second session at bilateral perichoroidal arteries. Well, we have reviewed the major types and important features of complicated aneurysms. These aneurysms can be found in normal practice and can be associated with worse outcomes and therapeutic difficulties. So it is important to detect them at the earliest possible time to provide the best management to the patients. Thank you very much.